Good evening, Puspendra sir. Welcome, sir.
Good evening. Am I audible?
Yes, sir, audible.
Yeah, and am I I'm sharing my screen. I think we are still not in a room, right? Um,
Yes.
wait, I'm sharing my screen.
Pushpendra
So,
sir, good evening.
hi, good evening,
Um,
good evening.
Hi. I just
I
wanted to tell you that I think the first speaker would be Dr. Akhil Santosh.
Yeah, yeah,
So yeah, so
right.
you can just switch on your video if you want, but then don't share the screen as of now.
No,
I
no
think
issue. No,
he
just
will.
it's okay, it's okay. We are starting at 7:30, right?
Yeah. Yes. I'll
Okay,
will
fine.
just
So
hit
I
the
will
start.
not share. It is just open here. Whenever you say, I will share. By the way,
Yeah, but then
ask.
we
Yeah,
yeah, but then if you want, you can have a demo of the sharing if
yeah,
you
that's
wish to
what
do
I
that.
want actually. Yeah, that's what I want. Can
Yeah,
I can I just have a
please
demo?
go ahead.
Yeah.
Please go ahead. Yeah.
Yeah, please.
I think Dr. Rui is also in. Hi, Dr. Rui. Good evening.
Hi,
Right?
good evening. Good evening.
I think now it is visible, right? My screens.
Yeah.
Yes, sir. Visible.
It is moving, right?
Yes, sir.
Fine. So let me unshare. है ना?
Okay.
Or I should do stop sharing, right? Yeah. Thank you.
Yeah. I
Thank you,
think
sir. Good
even I
evening,
will
Akhil,
try
sir.
to.
Uditya, sir, shall I start the program right 7:30?
Yes. We'll do that. We'll do that in another minute.
So, good evening, everyone. On behalf of the International Association for Integrated Oncology, IAIO, I warmly welcome you all to today's insightful webinar on lung cancer. We are honored to have an esteemed panel of experts with us today who will share their knowledge and clinical experience in this evolving field of oncology. Before we begin, it's my privilege to introduce our program director for today's session, Dr. Aditya Goswami, consultant medical and hemato-oncologist, SP Mediford Hospital, Thiruvananthapuram. Thank you, sir, for leading this academic initiative. Let's begin the session. I would like to invite Dr. Aditya Goswami to set the context for today's discussion. Over to you, sir.
Thank you so much for the kind introduction. And I think good evening to everyone. I'm really honored to get this opportunity. First of all, I would like to start off with uh, congratulating as well as giving my regards to IAIO Society for giving us all this platform. And we all being young medical oncologists are looking ahead for these opportunities. And I'm very happy to really head this session today. And I have been honored to have three panel members with me today. Dr. Pushpendra Hirapara from Ahmedabad, Dr. Akhil Santosh from MBR Cancer Institute, and my dear friend Dr. Ruhi from Rajkot. And overall, before I start off this session, I would like to tell you that when I was initially discussing about what the topic would be, I had seen that there were a lot of lung seminars, breast seminars going on. I felt that it was very much needed that something different was discussed. And in the era of personalized and precision medicine, there are a lot of cancers beyond NSCLC which really matter to our patients. And thus we have formulated such a program today where we are discussing a few unique situations beyond NSCLC, mainly the neuroendocrine tumors, the thymomas, and obviously the
रेड्डी से
transformed
पूछना है
SCLs.
रेड्डी से
So
ठीक है वो बता
without
देंगे ना
any
रेड्डी
further
का
delay, I would like Dr. Akhil Santosh to proceed with his first session. Akhil sir, are you there?
Yeah, hi. Can you hear me?
Hi.
Yeah, just wait a
You're
second,
audible
please.
and visible.
Yeah, so let me share my slides 1 second. Is my slide visible?
Yes, sir. Visible.
Yeah, are they moving? I hope they're
Yes,
moving.
yes.
Yeah.
Yes.
Yeah. Hi. Good evening, everyone. First of all, I would like to take this opportunity to thank IAO for giving me the opportunity to present today, and to Dr. Uditya for giving me the chance. So today we'll be discussing. Actually, we'll be discussing the less discussed. Actually, we've had so many discussions on NSCLC so far. So I had a chat with Dr. Uditya, and we thought we'll do something slightly different. So we'll delve into something that we usually don't come across very frequently, the mesotheliomas, thymomas, and the NETs. So without wasting much time, so I'll straight away go into my topic. So I'll be discussing basically management of unresectable advanced mesotheliomas and what current options that we have as of now. So, coming to a bit of on epidemiology, so this is something that we all are well acquainted with. So, we know that the main risk factors for mesothelioma are basically your occupational exposure to asbestos, which can also be environmental, as in the form of aerionite exposure, and a very few number of cases can occur because of radiation exposure, and around 5 to 10% are hereditary. The most common gene associated with the development of hereditary mesothelioma is BAP1, and other rare genes include your NF2 and TP53. And incidence wise, the highest incidence is found in Australia and Europe. And even despite a strong exposure, there can be a latency period of around 30 to 50 years before someone develops mesothelioma. And so again, apart from pleural, mesothelioma is also seen in the peritoneum as well as the pericardium and the tunica vaginalis. So in the interest of time, I would be restricting my discussion to the pleural mesotheliomas. And we all know that there are basically three major types of mesothelioma. The most common one is your epithelioid mesothelioma, which accounts for around 50 to 60 percentage. The next common is your biphasic, closely followed by sarcomatoid. So each one of them is around 10, 15 to 20 percentage. And prognosis wise, as you all know, epithelioid mesothelioma has got a better prognosis compared to your next. You have your biphasic, and the one with the least favorable outcome is your sarcomatoid one. And so this is something that we all are familiar with the latest AJCC staging for mesothelioma. So at first look, this might seem a bit complex and a bit difficult compared to your NSCLC, but actually this is much simpler. So, in short, basically your T1 tumors are your tumors which are just limited to your ipsilateral pleura with a minimal pleural invasion of less than 12 millimeters. T2 and T3 are somewhat, the components are similar, just that the pleural invasion thickness is different, less than 12 meters and more than 12 millimeters. Basically, T2 means fissural involvement and involvement of either your mediastinal fat or a solitary area of chest wall tumor invasion. And your T2 tumors are those tumors which have gross chest wall bony invasion or infiltration into your mediastinal organs, diffuse chest wall invasion, or a direct extension to your contralateral pleura, or presence of malignant pericardial pleural effusion. And unlike NSCLC, there is no entry in mesothelioma. So basically, it is N1 and N2. N1 is basically your involvement of ipsilateral intrathoracic nodes, and N2 is contralateral nodes or ipsilateral or contralateral supraclavicular lymph nodes. And so let's now come to the management of mesotheliomas. So let's start from scratch, from the chemotherapy era, and I'll slowly take you to the current management. So, before the early 2000s, basically the treatment of mesothelioma was basically done with single agent cisplatin. So, the outcomes of which were really poor. So, in the early 2000s, came the emphasis trial. So, emphasis trial basically evaluated the addition of pemetrexed to cisplatin And so this study was an RCT, which assessed the addition of pemetrexed cisplatin versus cisplatin alone. And so they found that addition of an antifolate drug like pemetrexed had an impact on the response rates, PFS, and the OS. So basically, this doublet regimen had a 3-month overall survival advantage versus a monotherapy with platinum alone. And thus, we had the standard of pemetrexed and cisplatin for metastatic malignant mesotheliomas. So we all are aware of the data from the Paramount trial with NSCLC, where the addition of pemetrexed maintenance had an around 2-month overall survival benefit. But this was not the case that was seen with mesothelioma. So in mesotheliomas, there was no benefit of continuing pemetrexed as a maintenance regimen. So this was basically seen in the CalGB 30901, where the trial was actually negative with just added toxicities with pemetrexed maintenance. But what they saw that what was that addition of a switch maintenance with gemcitabine in turn had a survival advantage in from mesotheliomas. So coming to the atomic meso study. So as you all know, there are two types of histology, basically your epithelioid and non-epithelioid. So what the researchers saw was that the non-epithelioid ones, your biphasic and your sarcomatoid. So basically these cells have the proliferation of the cells is dependent on an enzyme called argininosuccinate synthetase. So basically they found that deprivation of this enzyme. So basically by utilizing your PEG-arginase. So pegarginase was a compound which basically inhibited or caused a deprivation of arginine synthesis in the body. So addition of this enzyme to your conventional chemotherapy had a survival benefit in non-epithelioid varieties of mesothelioma. So basically, this strategy had a 2-month survival advantage. Unfortunately, this did not get widespread approval and is currently not incorporated into the guidelines and is actually being sidelined in the current immunotherapy era where you have a lot of other options currently available. And do tumor treating fields have a role? So in NSCLC, you all must be aware of the data in the second line, basically the Luna trial, which had shown a survival benefit of TTF plus chemotherapy versus your chemotherapy alone in the second line setting. Also, you have good data for TTF in other tumors like your gliomas in the upfront setting, and then in pancreas, in addition to your gemcitabine nab-paclitaxel. Similarly, TTF addition was assessed in the first line setting in malignant mesotheliomas, but this was just a single arm phase 2 study. Basically, they've seen that combination of TTF with chemo was feasible without any added toxicities, and the OS was around 18.2 months. But again, the numbers were very small, and the further RCTs with a larger population size awaited. But as of now, this is not a recommended strategy. And now coming to the main uh, treatment choices. So as of now, the study which established the role of dual immunotherapy in malignant mesothelioma is your Checkmate 743. This I think is the most important study in my talk. So basically here what they've seen is that they have tested the addition of nivolumab plus ipilimumab versus your conventional chemotherapy, that is cis or carbo plus pemetrexed. So here they have taken all unresectable mesotheliomas. They have stratified by sex and histology, epithelioid versus non-epithelioid. And here the dosing is unlike your melanoma. In melanoma, basically they have taken the reverse dosing. Nivo was 1 mg per kg and EP was 3 mg per kg. So here they have taken low dose EP, 1 mg per kg, and nivolumab 3 mg per kg. So they had given these drugs for either 2 years or until disease progression or unacceptable toxicities. The primary endpoint, mind you, was overall survival, and secondary endpoints were ORR, DCR, and PFS. And so this was the latest update, which was presented in last year's ELCC. So here they have seen that addition of Nivo plus EP had a survival advantage of around 4 months. So the median OS was around 18.1 month versus 14.1 month in the chemo arm. So the hazard ratio was 0.73, which was statistically significant. And so this is the most important part. So as you all know, this strategy has got a huge advantage in your non-epithelioid varieties. Basically, the survival, the gain was predominantly driven by your biphasic and sarcomatoid varieties. In epithelioid, the results were not that significant. HR is 0.84. In non-epithelial ones, the hazard ratio was a staggering 0.48. So, and the delta was around 10 months. So coming to the response rates, so there was not much difference in the ORRs between the two regimens. So it was around 40% in both, but the duration of response was more with your the dual immuno strategy. So this is the latest ASCO guidelines where Nivo EP is currently, the ASCO recommends that this regimen should be offered as a first-line systemic option. Despite the not so great results in the basically your epithelial variety, they still recommend this regimen for all, irrespective of histology. But the major benefit is driven by your sarcomatoid varieties. And coming to treatment-related side effects, as you all know, the grade 3 treatment-related side effects were slightly higher in the Nivo plus EP arm, but the treatment-related deaths, they were hardly very few in both arms. And if you see below, if you compare the risk and the benefit, the actual risk benefit ratio is favorable for your non-epithelial varieties. And so coming to the next important study, so this is basically your IND 227. So basically this study assessed the addition of chemotherapy plus immunotherapy. So basically here they have taken pembrolizumab plus pemetrexed plus cisplatin versus pemetrexed plus cisplatin alone. So initially they had designed the study as a phase 2 study with a smaller population lot. So but when they had seen encouraging results in the initial the patient set, basically they had changed the design into a phase 3 study. So here again, the primary endpoint was overall survival, and secondary endpoint was your ORR, PFS, tolerability, and health-related outcomes. So here what they saw was the median OS was higher in the chemotherapy plus pembrolizumab arm. It was 17.28 months versus 16.13 months. So the OS delta is hardly 1.5 to 2 months. But again, this is a lesson that we all know in immunotherapy trials. You should never go by the median OS. So if you actually see the Kaplan-Meier curves, the DOR is more with your immunochemo, and your 3-year OS is around 25% versus 17%. So those patients who get a benefit, they actually sustain that benefit for a very long duration with your chemo-immuno combination. And again, so this is something that we just saw in the CM743 study. The results were hugely driven by your non-epithelial varieties. The delta was around 4 months in non-epithelial versus hardly around 1 month in epithelial variety. And here in CM743, there was not much difference between response rates between the both arms. Here, the ORR was higher in the chemo-immuno arm. So if you want to choose between the two regimens, Nivo EP versus Pembro chemo, so supposing that if you need to give this for a patient with a heavy tumor burden or who needs a quick response, so I would personally suggest going for a pembrolizumab-based therapy. And there is good tolerance of the triple chemo regimen also. And as like Nivo EP, Pembro chemo is also advised by the latest ASCO guidelines, irrespective of histology. So let's now see some other immunotherapy studies which have been done. So here we have Beat Miso. So Beat Miso study was recently published in the last year ASCO. So here they have seen the addition of anti-VEGF plus immuno plus chemo. So basically they have taken the ABCP regimen that you all must be aware of, that has been studied in the IMPOWER 150 and your Beat CC study in your cervix. So basically, they have seen that Atizo-Bev plus chemo, this strategy did not have a benefit in the overall population, but there was a strong signal in your non-epithelial ones. So your sarcomatoid and biphasic had some PFS benefit and an OS benefit, but the ITT population, there was no benefit. So hence, this is currently not approved as of now. So coming to the Dream 3R study, so Dream 3R study again tested durvalumab plus chemotherapy versus chemotherapy alone. Again, it did not show any survival benefit. There was slightly higher, numerically increased ORR and PFS in the durva chemo arm, but again, OS was negative. So this is the first line in nutshell. So now let's come to the other second line strategies. So coming to the WIM trial. So WIM trial was conducted way before the IO era. So here they have seen they taken second line oral vinorelbine versus placebo. So here they saw that there was a PFS benefit in the oral vinorelbine arm. Unfortunately, oral vinorelbine is not available in India as of now. 4.2 months versus 2.8 months, and but there was no overall surveillance benefit because there was a heavy crossover from the placebo arm. And the other drug that is being used is pemetrexed if it has not been given in the first line. But all this data is before the IO era. So coming to RAIN study. So this is a very important study. So RAIN's technically what we in our setting we use as conventional second line in our uh, clinics post your chemotherapy or dual IO strategy. So here in RAIMS, they've tested the addition of gemcitabine plus ramucirumab versus gemcitabine alone. So here RAIMS was positive. Basically, it had an overall survival benefit with a improved duration of response in the gemcitabine plus ramucirumab arm. So this is the go-to second line regimen as of now. So coming to the other recent trials, so PEMELA 2 was recently published in the Lancet Oncology. So PEMELA 2 was a single arm study. Here, this was a contemporary study. So this was done in the IO era. So all patients were post Nivo EP in PEMELA 2. So in PEMELA 2, they have found that this Pembro plus Lenva had a very good ORR of around 60% and a PFS of around, I think it is around 7.5 to 8 months. And but again, the lenvatinib dose in Pamela is around 20 mg. So this, as you all must be aware, that this is a dose that we, at least us Indians, do not routinely use in our clinics because of the toxicities, and we still do not know how this regimen fares with a lower dose of lenvatinib. So I personally have very little less experience with this regimen in mesothelioma. So let's come to the studies of immunotherapy in second line. So basically, confirm tested nivolumab versus placebo. So confirm again, first line, the patients in the study got only chemotherapy. So if you have missed the bus and not used chemotherapy upfront, you may very well give it in the second line. This study had an overall survival benefit of 10.2 versus 6.9 months. But this was again a placebo-controlled study, but the results were slightly discordant with pembrolizumab. So in Promise Me So, they did not find any improvement in PFS or OS with pembrolizumab versus chemotherapy. So in Confirm, it was Nivo versus placebo that was positive, but Promise Me So was pembro versus chemo. And so, do CTLA-4 agents have any role in the relapse setting? So, this was again a negative study. So, there is no role of tremelimumab as a second line alone in mesothelioma. So this was the determined trial. And coming to MAPS2. So MAPS2, they have, it was a non-comparative phase 2 RCT. They have tested the role of, basically this was a feasibility study. So they have tested single agent nivolumab in one arm and nivo-ip in the other arm. So they have seen that both the arms had actually met their primary endpoints. They had good disease control with even a dual immunotherapy in the second arm. So, what are the newer options in the pipeline? So, basically, we have volrustomig. So, volrustomig, as you all know, it is a bispecific antibody targeting your PD-1 and CTLA-4. So, here they are testing in Evolve Me. So, basically, they're testing the lesion of volrustomig with chemo versus your CM743 regimen, Nivo-AP. So, the results are highly anticipated. And so, what are the other strategies that we have apart from our conventional chemo and immuno and bispecifics? So basically, as you all know, the regarding the genomic landscape of mesothelioma, we have a few genes like your BAP1, NF2, CDKN2A, which are the common culprits. So in BAP1 mutations, there is some signal for your PARP inhibitors, and your NF2 altered mesotheliomas. They have tried drugs altering your epigenetic pathway like your HIPPO and YAP inhibitors. And there is an upcoming role for CDK4 inhibitors in your CDKN2A mutated mesotheliomas. And there are upcoming roles for your anti-PRMT5 inhibitors for MTAP loss. MTAP loss is basically seen in CDKN2A mutation. And coming to antibody drug conjugates, so here I would like to mention the role of anatumab revumenib. So basically, this is an ADC which targeted mesothelin. So it had a promising result in the first line as a single agent, so it's in a phase 2 study. But the confirmatory study versus chemotherapy, that is anatumab revumenib versus vinorelbine, was negative, and so the further development of this molecule was stopped. So what are the other drugs that have been tried in mesothelioma? So there are upcoming trials for SG, for BV, and your other newer anti-mesothelin ADCs. None of them are currently approved as of now. So, do we have any predictive signatures for response? So here, from the exploratory analysis of two trials, basically a CM743 and Promise Me, so they have seen that patients who had a four gene inflammatory signature score composed of your CD8A, STAT2, and LAC3, and CD274. Basically, these patients they had an increased overall survival of around 21.8 months versus 16.8 months. So, what are the other promising targets that are worth looking into? So, here basically this was from a study which had assessed the whole genome sequencing of mesotheliomas and found potential targets like PTCH1, PDGFR, ALK, MTAP loss that I recently mentioned, BRCA, EGFR, and ERBB2. So all these molecules are currently being tried. None of them has so far produced any convincing results. So coming
Sorry,
and when
sorry to interrupt, sir. So
yeah,
2 minutes left in session. Thank you.
yeah, I'll finish it soon.
Okay,
So
sir.
coming to your screening. So is there a role for screening in mesothelioma? So as you all know, the most common gene associated with hereditary mesothelioma is your BAP1. So there is a criteria for testing for BAP1. Basically, in younger patients less than 50 years with no occupational exposure to asbestos and history of cancer in more than two relatives, and patients who have other features of BAP1 related cancer syndromes like your uveal melanomas, your cholangiocarcinomas, RCCs. So in these patients, you may test for BAP1 mutations. So what is the main feature of this BAP1? So basically, patients who have a BAP1, they are lesser aggressive tumors, they have a better prognosis, and they respond well with immunotherapy. And coming to Mars 2. So this is the last topic. I'll just finish in 1 minute. So basically, Mars 2, as the heading says, no mesothelioma discussion is incomplete without Mars 2 discussion, because this was a topic which created a lot of controversy in the medical oncology community. So basically, here they have seen that this was, mind you, this was done before the immunotherapy era. So here, basically, they have given this was basically done for resectable mesotheliomas. In one arm, they had given neoadjuvant chemotherapy followed by surgery, and in the other arm, they have continued with only chemotherapy. They have not done surgery. So here, what they found was that patients who had undergone surgery, they had a detriment in survival. So they had more serious adverse events, worse quality of life. So basically, this was a deterrent against surgery. So basically, the chemo arm had better outcomes in Mars 2. So again, so this created quite a bit of confusion in the oncology community. So they went and went deep into the paper and saw what were the factors which led to the negative results for surgery. So here what they've seen was that they had included a big chunk of sarcomatoid and non-epithelioid tumors. So basically, even if you see the ASCO recommendations, the main criteria that they say for surgery is that patients who have epithelioid mesothelioma and T1 to T2 tumors, they fare well with surgery. So in Mars 2, they had a lot of patients with sarcomatoid and biphasic. And the patients did not have a proper PET staging in Mars 2. So they could have taken a lot of patients with an advanced disease also. Also, they did not have proper mediastinal staging also in this study. So there was no PET staging, no mediastinal staging, a lot of patients with non-epithelioid variety. And the study was done in a lot of centers which were not well versed with mesothelioma surgeries. So they had not taken a lot of low volume centers also. So this was another flaw associated with the study, and this is the main important point. There was a lot of imbalance in subsequent treatments. Basically, your chemotherapy only arm had a lot of patients receiving subsequent treatment and a lot of patients completing your chemotherapy. So this again was a flaw in the study, which was later outlined. So what is the future? So in the future, so we are moving slowly towards induction immunotherapy in unresectable and locally advanced mesotheliomas and perioperative immunotherapy. So we are slowly moving away from upfront surgery and upfront neoadjuvant chemotherapy. So this study came in Nature here where they have taken perioperative Nivo or Nivo-IP. So they have found that around 80% of patients proceeded to surgery with a very good PFS and OS with no added toxicities. So maybe, but this was a very small phase 2 study. So I think this is the way to go forward. So I think this is my last slide. I think I'll stop here. Yeah. Thank you. Over to the organizers. Yeah.
Yeah, thank you, Dr. Akhil. Thank you so much for giving us so much information in a brief period of 20 minutes. I just wanted to finish off, and I'm aware that you have a meeting in another 2 to 3 minutes. Just wanted to discuss a few points with you. First of all, tomorrow morning clinic, a non-epithelioid variety comes to us, and then so our choice for treatment would be in the first line would be ideally a Pembro with pemetrexed and cisplatin or a Nivo EP based on the disease burden is what I understand from you. Yeah.
Yes, for non-epithelioid ones, we don't have a confusion as of now. It is basically you can go ahead with either of Nivo-IP or Pembro plus chemo. But as I mentioned before, the response rates were higher with Pembro plus chemo. So if you have a patient who wants a quicker response with a heavy tumor burden, or borderline resectable, or you want a conversion sort of a strategy, so I think it's better to go with Pembro plus chemotherapy rather than Nivo-IP, because otherwise, even the ASCO recommends either you can go ahead with both in non-epithelioid. For
Yes.
epithelioid, actually, the jury is still out. The actual benefit with addition of immunotherapy is less, but still the guidelines recommend the same.
Okay. So for us tomorrow in the OPD, if we have a epithelioid, we shall I really
And
give my
yeah,
call here?
Oh, sorry to interject. So
Sorry.
for
Tomorrow.
epithelioid ones also,
Right.
addition of bevacizumab to chemotherapy is also a very good strategy. So as per the MAPS trial. So even it's wrong to compare cross trials. Even the median OS in that study, which compared bevacizumab plus chemotherapy, was around 18 months. So that was the same OS that you got in the double IO study. So if you're not going by an immunotherapy-based strategy in epithelioid, addition of VEGF would be a good option, good reasonable option.
Right. And the last point to discuss with you is that second line, you would be happy to give gemcitabine, ramucirumab for both varieties, epithelioid and non-epithelioid?
Yes. So in that study, unlike the Checkmate 743, the magnitude of benefit was similar. The hazard ratios were similar in both epithelioid and non-epithelioid. So I think that would be a VEGF inhibition has got a good role in both epithelioid and non-epithelioid. But again, RAMES study was done before the IIO came into practice. So we actually don't know how many patients would actually respond in practice, because majority of the patients were post PEMSIS in that range study. So we still are lacking good data for post IIO options. So,
Understood.
but in theory, it works. Anti-VEGF works.
Thank you so much. I think we are running out of time, but Dr. Akhil, if you can just give us 30 seconds more to Dr. Muthu
बंदा
has
बोल रहा था
asked
वहां
us
पे
three doubts. The role of
Yeah, sure,
बोल
sure,
रहा
sure.
था
the role of
क्या
high
बढ़
talk.
सकता है
I'm not aware of
फिर
this high talk actually. You can shed some light.
दोनों खाने
And
वाले थे
then, do we recommend screening for family members with BAP positive? I think you have
वो
already
सब लोग
answered that.
Yes, the BAP one I had mentioned the criteria for staging. Basically, less than 50, then patients with other BAP cancers and your epithelioid varieties. So basically, they have and patients who have no exposure to asbestos. For those patients, you should screen for BAP. Are there any therapeutic benefits of it? No, and none as of now. It's basically prognostic. And basically, your BAP ones they have a very indolent course, and so they have a good prognosis.
Right,
So that
right.
is.
And CDKN2A positive, can we recommend CDK4/6 inhibitor? I think we are
The
talking
trials
about,
are ongoing.
yeah,
Trials are ongoing as of now. We don't have any concrete data as of now. But compared to BAP, the prognosis for CDKN2A and NF2 is very bad. Yeah.
right, right. Thank you so much, Dr. Akhil. Thank you so much for your
Yeah.
insights.
Thank you. Thank you. My pleasure.
Yeah, thank you so much. I think without further delay, we'll go ahead with the second talk of the day. So, Pushpinder sir, you can take over actually.
Hello. Is my slide visible?
Yes,
Yes.
sir.
Uh, yeah. So, thank you, Dr. Udipatya and IAIO for inviting me to deliver this talk here. Without wasting much time, I think my slides are visible, right? Yeah. So, topic provided to me is stage 3 thymoma, traditional approach versus IO-ERA strategy. So, let's see what is the trend globally about and the mortality of thymic epithelial tumor. And if we see, the incidence is like 1.3 to 3.2 per million person years, and the incidence has been shown gradually increase over last 2 decades. And the peak incidence usually occurs in the middle age, 45 to 55 years, and there is no strong gender predominance, though some cohort studies have shown either male or female predominance. Now, what about thymoma and its incidence in India? So I am quoting here two studies. One is from TMH and another is from JCRI. Basically, it's a observational study. Median age is 51 years in TMH study, and majority are diagnosed in stage 1 and 2. The WHO subtype B was most common, and median OS they reported was 60 months. The GCRI study, male predominance, majority in stage 1, and subtype B2 was the most common. Metastasis occurred in 20% patients at time of presentations. So, before we move on to the topic, we'll spare few minutes on the staging. So, since 1978, there are around 15 different staging system has been proposed. The most widely known was the Masaoka system, which was designed by surgeon. There were refinement like in 1994 and 2011, and presently we are following AJCC. Recently, we have 9th edition also, and this is based on the ITMIG database of more than 8,000 patients. And presently, this is to be used as per the recent guidelines. So, stage 1 is basically a completely encapsulated tumor. Stage 2 is microscopic invasion into the capsule or macroscopic invasion into the surrounding fatty tissue. But the today's topic of discussion is on stage 3. So, as this slide shows, so it is either direct mediastinal pleural involvement or partial pericardial or vessel invasion, or it is direct penetration through visceral pleura, pericardium or vessels. But as compared to stage 4A, where there is a separate pleural nodules or pericardial nodules or a distant mats, this can be upfront resected or potentially resectable. So that is our today's area of discussion. This is HSCC 8 staging, where the stage 3A is invasion into the lung, chest wall, frenulum, and brachiocephalic vein. But T4 is basically unresectable, which means invasion into aorta, pulmonary artery, myocardium, trachea, or esophagus. So, if we see, there is a stage migration from Masaoka Koga to HSCC 8th edition. There is a majority of the stage 2A now will fall into 8th edition stage 1, and stage 3, which is pericardium T2, is in stage 2, and T3 and T4 is now stage 3A and 3B. So majority of 2 will migrate into stage 1, and stage 3, if pericardium involvement, will migrate into stage 2 as per 8th ADCC stage. Now this is the 9th TNM classification, and if we see in stage 3A, the one as compared to 8th edition, the lung, parenchyma, and phrenic nerve extension is moved from 8th to T3 to T2. But the direct invasion of either brachiocephalic vein, superior vena cava, chest wall, or extra pericardial hilum is now T3 and 0. And if there is a direct invasion into the major vessels, basically that is T4 and it is stage 3B. So this is a tumor histological type. And if we focus on the 9th TNM staging, only 6% will fall into the histology wise A. Majority will be AB, 9.6% is in B1 and 18% into B2 in stage 1. but our area, today's topic is 0.6%, stage 3, which is B2. So this is the alluvial diagram. And from Masaoka Koga stage to 830 nm and then 90 nm, if we see from 8 to 9, among stage 2, the 3A, which is now considered as to be stage 2, and few portion of the stage 3A will be now again stage 3A. And they have shown that the OS also difference, and TNM is a better predictor of outcome than the Masaoka Koga staging system. This is the one slide on the histological type. Clinically indolent are A and AB, and aggressive are basically B2, B3, which are known to cause the metastasis. So with TNM9, today's area of discussion is T3, which is potentially or upfront resectable, and T4 is unresectable, which is basically 3A and 3B. So let's move to the topic, the traditional approach or the current algorithm. So basically it is T3, T4, N0. We have to discuss it into the MDT. If it is a upfront resectable, subject patient to the surgery, provided patient is fit for surgery and we get the fitness. If there is a clear margin, they suggest observation, but now we will discuss more on this part. If the margins are positive, then post-op radiotherapy and to be added a concurrent chemotherapy, adjuvant chemotherapy also 2 to 4 cycles. But if it is unresectable, we'll start with the neoadjuvant therapy and reassess. If it is resectable, then subject patient to the surgery, and these all patients which are downstage by the chemotherapy needs post-operative radiotherapy. But those who are still unresectable to be treated with definitive chemoradiation. This is the current treatment algorithm or flowchart for the stage 3 thymoma. And our goal is to complete resect and to improve the optimal outcome. Now, these are the traditional approach for the surgery, open, video assisted, robot assisted. Our aim is to achieve the R0 resection. But here, even R1 and R2 resection has a better survival than the biopsy alone. So 5-year survival improved from 24 to 40% to 60 to 75% if we do at least R1 or R2 resection from only biopsy. But definitely the goal should be R0 resection. So we will now discuss few studies. Definitely we don't have much phase 3 studies. It is mostly phase 2 studies. And these studies, what they did is they included all multimodalities. So they started, they included the stage 3 and stage 4 patients, 22 patients, median age was 47 years. They give 3 cap regime, then assess for the surgery, then all patients receive the post-op radiotherapy, and then 3 consolidation cap. The response measure were 77%, and R0 resections were 76%. All received post-operative radiotherapy, and their outcome is 5-year OS is 95% and 80% at 7 years. And progression-free survival at 5 years was 77%. These study conclude that the induction chemotherapy to optimize the surgical resectability, followed by radiation therapy and consolidation chemotherapy, leads to the higher overall survival rates. But this is basically a phase 2 study. The another trial, what they did is they changed the chemotherapy regime and they delivered 9 cycles of weekly chemotherapy, but they used the 4 agents like cisplatin, VCR, doxo, and etoposide. They delivered post-operative radiotherapy as per the R0 or R2 resections, 48 gray versus 60 gray dose. 57% underwent a surgery, and OS was 85% at 5 years and 69% at the 8 years. And they say that the weekly dose-dense chemotherapy has activity similar to that of the conventional regime, but they are not the head-to-head. This is again a phase 2 clinical trial, which is a single arm, and they included a patient of stage 3 and 4. They give 2 cycles of CC topo, and then they reassess the patients. And also they delivered the new adjuvant radiotherapy, 45 gray. They got the 45% of partial response, 50% of stable disease. There was no complete response, and on surgical specimen, 24% has a major pathological response. 5-year OS demonstrated was 71% with multimodality therapy. Now, what about the radiation therapy? So they are mostly database cohort studies. And they are saying that as per the Masaoka stage 3 and 4, they improve the OS. But if there is a R0 resection, then the benefit is uncertain. And it also depends on the type of histology. Like they are more likely to respond B1 and B2 than the other side, like B3, which is more aggressive for distant mets. The dose range were as per the resections. If it is R1, they deliver 45 gray or 50 gray. And they suggest that for stage 3 disease, it improves the OS also from 80% to 92% as compared to the surgery alone. And 10-year OS is improved from 64% to 76%. They also have tried SBRT at a median of 56 gray and got a local control of around 80% with median PFS of 28 months in selected patients for unresectable patients. But these studies also included the thymic carcinoma. So what about definitive chemoradiation therapy? This is the evidence where the patients which are still unresectable after downstaging chemotherapy or upfront unresectable, they deliver total dose of 54 gray and 2 to 4 cycles every 3 weekly with cisplatin, adriamycin, and cyclophosphamide, which is basically a sequential regime. And they reported that the overall response rate was around 70%, and the median survival time was 93 months, and the 5-year survival rate was 53%. So basically, those who are unresectable can be subjected to the definitive chemoradiotherapy. With availability of protons, there are few reports that they have also utilized the protons for definitive radiation. Now,
Sorry to interrupt, sir. Sir,
yeah,
2 minutes
yeah,
left in the session.
sure. So basically, for whenever there is a stage 3 as per the current staging system, the propensity score match cohort study suggests that the adjuvant chemotherapy improves the 5 and 10-year OS. And they have also reported few patients with cytoreductive surgery with HIPEC. Practically, we have not seen. These tables suggest the benefit of or the trials which have shown the activity of targeted therapy. Practically, except lenvatinib, none of them have shown the benefit clinically. And this is the overall response rate and basically PFS in months with the different agents. So they have also tested the lenvatinib in the second line, and the objective response rate was around 38%. The common side effects were hypertension and the palmoplantar erythrodysplasia syndrome. So what about the immunotherapy? Because that is the title. So majority of the patients have more than 50% of expressions, but there is a low TMB, and there is a high incidence of autoimmune paraneoplastic syndrome, particularly in thymoma before at time of diagnosis. So this was a pembrolizumab study. Another, there was a Korean study. Both of them are phase 2 studies. Overall response rate are in tune of around 20 to 25%. But the important point to note is that more than or equal to grade 3 immune-related adverse events are in tune of 15 to 20%. So we need to be cautious. There is a study for nivolumab. There is no response rate, but disease control rate was 73% and 13.3% more than or equal to grade 3 related immune-related adverse events. They also tried Nivo plus EP in Nivodhyme phase 2 trial. There was one arm and they didn't show any clinical benefit. If we see the grade 3 or 4 adverse event, it is in tune of 57%. So then this is a Picati trial where they combine the lenvatinib plus pembrolizumab. They also included the patients of thymic carcinoma. That was a basically phase 2 trial. Dose was 20 mg OD and pembrolizumab 200 mg IV every 3 weekly. The 84% patients were the thymic carcinoma. Stage 4 patients, the primary endpoint was 5-month PFS, which was improved and it was met. But the grade 3 or worse adverse events were 37% and immune-related adverse events were 14%. But they say that if the patient is basically pre-treated and refractory to the chemotherapy, you can combine immunotherapy with TKI. So this would be my last slide. So what is any update for stage 3 thymoma? I think nothing changes because higher incidence of immune-related adverse events. But if patient is not suitable or fit for definitive chemoradiations, or if their morbidity is high, we can consider considering the high incidence of immune-related adverse events, either IO alone or IO plus TKI. With that, I would like to conclude. I again thank you, Dr. Udipatya and IAEO for providing this opportunity. Thank you.
Thank you so much, sir. It was actually when we were discussing initially, it was a slightly dicey discussion. But
Yeah.
what I wanted, and you told is absolutely correct. We wanted to just discuss 3 and 3B separately. That all both comes in the same umbrella. But then,
Right.
yes. But then tomorrow morning, if I have a patient. Uh, what should I do in a 3A patient? The surgeon says that I'm not able to resect. So should I go
So
ahead?
definitely, yeah, yeah. So definitely neoadjuvant therapy. Now we have two regimes basically. So basically they tried three regimes: CAP, pegcilcarbo, and C-Topo also. The patient can tolerate therapy well, then go ahead with the CAP because highest OARR. But then there is a marginal addition of toxicity also. Pegcilcarbo can definitely consider for a frail or ECOGPS kind of two patients. After a reassess, so basically upfront resectable, there is no question. You resect, and depending on the post-op histopathology, either you subject to the RT or chemo RT. But for marginally resectable, you can consider with neoadjuvant chemotherapy. Upfront unresectable, anyways, there is no data where we can start directly upfront chemoradiation. I think we should give some kind of chemotherapy and downstage, and then see the either definitive chemoradiations, or if not fit, then we can give anything like IO or IOTKI, but
Absolutely.
considering high incidence of toxicity.
And as we are discussing about all the topics, I think soon IO is going to come as a partner with chemo in the neoadjuvant setting as well.
Yeah, periopo. Yeah. So
And
practically, I have not given any immunotherapy for thymoma, but in national and global group, I have seen some discussions where they have tried typically IO agents. I
yeah.
have not given. Yeah.
And one more scenario I wanted to discuss with you is that, for example, we were talking about the patients whom we have given neoadjuvant chemotherapy, and then still that patient is not resectable. In that area, that is also a gray area where whether we should
Agree.
give radiation or whether we can place immunotherapy there is another discussion that.
Agree. So we don't have a data because whatever the definitive chemoradiation studies are pre-IO era.
Right.
And with frankly speaking, like before I practice radiation also, so in last 10 years I have seen only two patients of thymoma in clinic. So conducting a head-to-head trials is not also possible. So it would be mostly phase 2 trial, and then you just compare cross comparison studies.
Right.
But yes, that is the area of gray zone where we don't have a data.
Yes. Thank you so much, sir. Thank you so much for your time. I think.
Thank you.
Thank
Welcome. Thank you. Over to organizers.
I think we'll go ahead with the third session. Dr. Ruhi Kumar would be presenting that. So over to Ruhi.
A very good evening to one and all. Thank you to IAIO for inviting me, and thank you, Dr. Udiptya, for having me present this topic. And initially, when he had sent me this topic, I was a little worried as to what I would talk about. So I'll just share my slides. Are my slides visible?
No, ma'am, not yet.
Okay.
Yeah, visible.
So go into slideshow mode. So are my slides visible?
Yes, ma'am, visible.
Yeah. So I'm going to be talking about metastatic large cell neuroendocrine carcinoma lung. So should we treat it like a small cell lung carcinoma, or should we treat it like non-small cell? It's basically like Po in Kung Fu Panda having a identity crisis with two molecular parents, and we now want to see who should we treat like. And so I want to start with large cell neuroendocrine carcinoma. First of all, we see lung cancer so frequently in our practice. It's the fourth most common cancer in India as per the latest Globocon data, and it is the second most common in men. And but the large cell neuroendocrine carcinoma type accounts for 2 to 3%. So how many of us have seen this subtype in our setting in our daily practice? So In fact, I had one patient recently. I'll get into that soon. So, large cell neuroendocrine carcinoma is basically large polygonal cells. Just, yeah. With moderate to abundant cytoplasm. IHC is usually what we use to guide our treatment strategies, and they have TTF1 positivity, and neuroendocrine markers are positive synaptophysin, chromogranin A, and Ki67 is high, around 40 to 60%. What we have to see is it shares a lot of neuroendocrine markers with the small cell subtype. So historically, we know that we treat it like a small cell lung cancer. So also this large cell subtype can be a subpart of adenocarcinoma as well. Sometimes it behaves like a non-small cell lung cancer. And just 1 second. Yeah, so non-small cell lung cancer. So where the CK7 and CK19 was positive. So I had a patient recently where CK7 and CK19 was positive, but all the other markers were negative. TTF1, napsin A, P40, P63, and synaptophysin, chromogranin A. So we treated like a. So I went back and discussed with my pathologist, and they said that it looks like a large cell type. So what we want to see is whether it's a neuroendocrine type or non-neuroendocrine type, which will also affect our treatment strategy. So historically, it was large cell neuroendocrine carcinoma was historically treated like a small cell lung cancer, and it was one treatment strategy to fit all. But now, as we move on to the precision oncology era, we know that's not true anymore. So each LCNEC is different. Again, it consists of 2 to 3% of all the lung cancers. It's a WHO high-grade neuroendocrine carcinoma. Median overall survival is very poor of metastatic disease, which is often less than 1 year, and treated like SCLC. And molecularly heterogeneous, it is very heterogeneous subset of cancer, and it's a biologically split disease. So our key question is, what is the genomic landscape? Is it SCLC-like, where the key genomic alterations are TP53 loss or mutation, RB1 loss, MYC amplification, SOX2 amplification? Do we have this DLL3 overexpression? And we all know we have a target against this. I'll come to that. And or is it non-small cell like, where the typical genomic alterations are the KRAS mutation, STK11 mutation, or the KEAP1 mutation, or any of the subsets that we know and love, like EGFR, ALK, and ROS. So NEC is not a single disease. I think we're in this era of precision oncology, we all know that we are finding out that we cannot just label every disease the same way. So we are at a molecular crossroads with this disease, and genomic profiling is extremely essential to guide our treatment decisions and clinical trial designs. So what are the differences when this LCNEC behaves differently? When it's small cell like, the molecular and genomic alterations are different. As I just mentioned, it's neuroendocrine type biology. It's DLL3 enriched, and the platinum etoposide therapy has a better response. And the NSCLC like has a different genomic alteration. It has a very mixed biology, and this type of disease benefits more from paclitaxel or a pemetrexed based regimen, depending on the guided by the molecular markers. So based more than histology driven, we are moving towards a biology driven treatment. And this landmark paper of how this is a diverse disease was done by this Dr. Natasha Rechtman. She devised a molecular classification where she said that this is a diverse disease in itself. She is a doctor in MSKCC, where she is working just on this subtype of cancer. So what does the data say? What is the data that we have? So as we all probably guessed, there is no definitive phase 3 randomized LCNC specific data, and evidence is largely retrospective, cohort based, extrapolative, and the molecular stratification is increasingly guiding our treatment decisions. So depending on which way the biology is leaning, that's how we tend to choose our treatment strategies. And that's how it gives a better survival advantage as well. So one regimen for all is probably not the best strategy anymore, and we should leverage the NGS and all the techniques that we have in our hands right now. So why should immunotherapy work at all? This table is extremely important because immunotherapy makes sense in LCNEC because there is a high tumor burden. So high tumor burden means it's a immunologically active tumor, and hence our treatment strategy against it. And smoking associated mutational burden is also high. PDL1 is variably positive, but as we all know, PDL1 is not a perfect marker. And neuroendocrine tumors may still respond despite low PDL1. So again, PDL1 not a very perfect marker, an imperfect marker. So there are retrospective studies which show meaningful responses to IO strategies, and activities seen both in chemo plus IO and later line IO strategies, and responses may resemble small cell lung carcinoma more than non-small cell, but again, it's not one size fits all. So IO is increasingly getting integrated in this subsite of cancer as well, which is smoking related, genomically unstable, and potentially immunogenic. Since we don't have any direct data from phase 3 randomized studies, we have a lot of extrapolation data where we live in two parallel worlds, leveraging the landmark practices in SCLC like data, where there is atezolizumab, durvalumab, and in these tarlatamab DLL3 targeted agents, which are highly promising with the overall objective response rates of 40 to 50%, with the duration of responses of 7 to 11 months. And non-small cell like strategies like pembrolizumab plus chemo, and atezolizumab, durvalumab, nivolumab, ipilimumab combination. And now there are these drugs, serplulimab and tislelizumab, which have entered our market. These are the Chinese molecules, and they are more relevant to us since it is financially more accessible to the patient currently. Of course, nivolumab is now accessible as well, but these are more financially accessible to our patients. We are spoiled for choice in NSCLC first line. There's durvalumab studies, there's serplulimab, tislelizumab, atezolizumab, single IO combination or IO CTLA4 based combinations. And like I mentioned, the Chinese molecules are doing well. And personally, I've had some experience with giving serplulimab, and it is doing really well in our real world setting. So how do I approach if tomorrow I see a patient in my OPD with metastatic large cell neuroendocrine carcinoma? What do I do? My first strategy would be to get an NGS early. And I'm sure we are all doing this in our practice, and an NGS is an extremely important piece of paper. It's like the dragon scroll in Kung Fu Panda, which is like one which guides us to figure out what we should do next. Again, this is an SCLC like strategy: platinum etoposide, adding an IO, considering targeted therapies which are under trial, under ongoing trials, or an NSCLC like strategy with platinum doublet plus minus IO, and any if or any targetable mutations are there, so we can go ahead with that. But when the scroll came up empty, and that's usually what happens in our day-to-day practice, where the reports are either non-targetable, or they do not they have a lot of VUS which we don't really know what to do with yet, or if the patient is not financially affordable to do this study. So we take a pragmatic approach and fall back to our SCLC like treating regimen strategies, because we do know they work. We just would prefer to do a precision oncology based approach, which is molecularly driven. So what do the guidelines say? Current guidelines, ESMO, NCCN, NCG guidelines, what do they say? It's there is a huge evidence gap in this subset of lung cancer, which is large cell neuroendocrine carcinoma, because we don't have any prospective phase 3 randomized trials. That's also because we have very less number of patients in our setting. And platinum etoposide is the widely accepted backbone, which is extrapolated from the ES-SCLC data. Of course, we are moving towards precision oncology, and we have a lot of extrapolation of data from SCLC and NCLC like data. These are the leading voices in the field. Dr. Natasha Rechtman, who pioneered the molecular classification. Dr. Jared Weiss, he's doing phase 2 trials. And Dr. Alex Drillin, who is also advocating for a molecular driven therapy in this setting. So where is this field going? Where is the future? So I believe we are living in the future in a sense where IO is exceedingly becoming a very important part of our treatment strategy, where we do chemo IO intensifications, maintenance IO strategies, and neuroendocrine targeted therapeutics. These are all under investigation, and this is where our future lies. The emerging strategies are also like tarlatamabs, the bispecific antibody, and the molecularly stratified trials, the basket umbrella trials, which are ongoing, and the IO combination strategies. So should we classify large cell neuroendocrine carcinoma by morphology or by molecular identity? This is also true for all the other cancers and our practice in general, where we are moving towards very specific to the patient type of a treatment approach. And this is the future in LC, NEC as well. So these are my take home points. This is a very molecularly heterogeneous disease, and it's not one size fits all. It's not that all should be treated like SCLC strategy, which we are currently doing. And the genomic alterations, they help us decide which paradigm it favors, whether it's an SCLC type or an NSCLC type. And immunotherapy is increasingly important despite the limited prospective data. So this calls for long-term and multi-centric trials, because we have very less number. NGS is the basis on which we are devising our treatment strategies, and it should be considered as early as possible in the metastatic disease. So the question is no longer SCLC or NSCLC. The real question is, what biology are we treating? Treat the biology and not the label. And that's where we are moving towards next. So like Po, we will compromise on learning from both our molecular biological fathers. So thank you so much. And thank you once again for the organizers for having me be a part of this wonderful talk beyond NSCLC.
Thank you, Dr. Ruhi. I think nice cartoons and a nice presentation. I think you mentioned about Jared Weiss, and he has done a lot in the Caspian trial and a lot of studies on durvalumab maintenance and everything. Just wanted to discuss with you one thing, is that if, for example, it goes towards the left, that means that it goes towards a SCLC type of situation, then would you be interested in doing a PDL1? Because when we go ahead and we see this patient in the clinic, would we at all do a PDL1 in this setting in the present era?
So I think that's a very good question, actually. But in metastatic setting, upfront, we are sending everything simultaneously. So an NGS PDL1 has to be sent as early as possible. In fact, if the patient asks me if what is important, like if I have to send only a few specific markers because I don't have the money to do the entire NGS, so PDL1 is an extremely important marker. And as the data is emerging, there are are two sides of the coin. One is that PDL1 is an imperfect marker, and sometimes the treatment IOs are working in NEC type cancers despite low PDL1s. And the other side of it is we don't really know. We are just assuming because the numbers are so small that we don't have enough data to generalize the biology of the disease as of now.
Right, right. And one more thing, that when we are talking about LC-NEC, I think a broader NGS panel is the most important thing here, because as you mentioned that we are looking at TP53 and RB1 and then STK and all this. So I think nowadays with the new various companies and competition around, I think a broader NGS panel is almost now nearing and becoming cheaper and cheaper. So would you like a broader NGS panel or still stick to actionable mutation panel itself?
So that's also a very good question, because now we have like hotspot panels and all these lung specific panels, but a broader NGS panel is always the test of choice. And even for NSCLC, I have attended meetings where like a lot of senior doctors are mentioning that we don't really know whether these are the only hotspot mutations which are relevant in our treatment driven precision oncology strategies, because there are so many epigenetic regulations. And even the VUS, sometimes when the VAF is really high, we might not know the uh, importance right now, but it is going to help us in the future. So a broader NGS panel is always the test of choice, and that's what I recommend to my patients. If when they ask me to go specifically, then I only try to do strategies where I know that there are target therapies or immunotherapy available which can help treat the disease as well. Otherwise, broad NGS.
Great, great. Thank you so much. I think Dr. Vedant has asked about what percentage of LC-NEC has actionable mutations. Anyways, LC-NEC is 1 to 3%, but you can always take that, yes.
Yeah, so it actionable mutation, I'm not really sure actually what is the percentage, because like I said, so I had one patient who had this large cell carcinoma, and all the IHC markers were negative. So as you know that we have to decide chemotherapy also based on that, and patient was not affordable for NGS panel, and it would take time. So I discussed with the pathologist and went with, and then they told me that it looks like a large cell type of cancer, and the patient didn't want to do further IHC for synaptophysin chromogranin also. So, like this is the real world setting where we are working in. So even if we get one or two patients, then getting to do an NGS on them and finding out what percentage of markers will be there. I'm sorry, I don't really have the answer to that right now.
Right. But thank you so much, Dr. Ruhi. I think it was excellent. Thank you for making time. And as I told in the initial part also, that it was a tough thing that we had decided to do beyond NSCLC.
I felt like my these topics are, although they are very beyond NSCLC, I think my specific topic did not have any direct data. So it was very thought-provoking and challenging. And thank you for always putting me up to the challenge, Dr. Udiptya. Thank you so much for the invite.
Sure. Thank you so much.
Thank you, sir. Thank you, ma'am, for that excellent talk. Now I once again invite Dr. Uditya Goswami, sir. Over to you, sir.
Yeah. So shall I start? Yeah. It's visible, right?
Yes, sir, visible.
Yes. So I've come to the last session today. And so another challenging topic, another topic which does not have much data, but slightly better data than of late in the last 1 year. So I'm going to talk about histologically transformed SCLC from NSCLC. It's a very clinically relevant resistance mechanism. Just 1 second. So we have discussed multiple times about what are the acquired resistance in EGFR mutant NSCLC, and if we broadly classify, it's basically the on-target resistance, the off-target, and the histological transformation. The on-target, as we know, that it's the T790 mutations, the C797, and the EGFR amplifications. And then obviously there are some bypass pathway, the downstream signaling. The bypass most commonly is the MET, then we have the HER2, and the downstream signaling pathways, if you see the picture here, is that PIK3CA, PTEN loss, and we have a BRAF. And then the phenotype transformation is the SCLC or the EMT pathway. And then there are some heterogeneous or polyclonal resistance that are rarely seen. Now, coming to the main discussion today is SCLC transformation, and we have seen that it's reported in 3 to 15% of patients who are on EGFR TKI mutations, on TKI, EGFR TKI drugs. And obviously, the resistance cases vary depending on the cohort and the different methods. Now, coming to the basic of how an SCLC transforms to a SCLC is based on the lineage plasticity, where the tumor cells retain the original EGFR driver, but they undergo a neuroendocrine differentiation, and that is under the therapeutic pressure. Obviously, we are giving the drugs, and on the therapeutic pressure, it's changing. And as mentioned by Dr. Ruhi, that transformation is typically associated with loss of RB1 and TP53 tumor suppressor function. And obviously, there is acquisition of neuroendocrine features. We know that synaptophysin chromogranin. And in a recent cohort, we saw that all cases expressed one marker at least. Now, this is a little different from when we have a transformed neuroendocrine prostate cancers. In those cases, it's not necessary that one neuroendocrine feature has to be expressed, but in lung, it has to be. So that's a basic difference. And reduced EGFR dependence despite the retained mutation. So here I am going to talk about it a lot later. Now coming to the pathology and the diagnostic clues that we can get, the pathologist can see a high nuclear to cytoplasmic ratio. There can be a neuroendocrine morphology, and obviously the expression of the markers is going to be checked. So the morphology will be obviously when if it's original NSCLC, it would be glandular lipidic. Once it becomes SCLC, it will be small cell, high NC ratio. There will be molding. The IHC markers, which was initially TTF1 napsin, will become now synaptophysin. We know that very well. The activating mutations, be it EGFR mutations, be it exon 19 deletion or L858R, will be retained. And obviously, the biopsy trigger would be there. And here, in transformed SCLC, we are going to talk about it, that rapid progression and discordant lesions, where there are mixed response in different lesions, would be an indicator. Now, who is at risk of transformation? We have spoken about it, that concurrent RB1 and TP53 alterations are a subgroup that is at a higher risk. But then let us break more into the details and go to the studies that have been done. So Ofen et al. Had seen that 5% of the EGFR mutant cases had a triple mutation, which is EGFR, RB1, and TP53. 18% of these triple mutant cases actually transformed into SCLC. That is like 1 in 5 patients who have triple mutations are transformed into SCLC once in their lifetime. However, only 30% of this transformed SCLCs from a EGFR mutant had both RB1 and TP53. So what I'm trying to say is that having a co-mutation of RB1 and TP53, even though they are not very common, that is only 30%, but then there may be some other contributory factors which may lead to this transformation, which we don't know yet. And generally, multiple studies have been done. We have seen that they generally come late. That is, the median time of transformation is 18 to 27 months. We have some reported data of 3 to 4 months, but then they're not very common. Now coming to the common alterations in transform SCLC, and we know these, that EGFR, RB1, T53, PIK3CA, and MYC. Now, obviously, clinically, I've already discussed that how to understand them is that rapid symptomatic progression on a EGFR TKI, a new bulky disease, a rising neuroendocrine phenotype suspicion. And then the main important is discordant behavior across the lesions. The main primary lesions are decreasing, but a new lesion has come up, or there is some reduction in the size of a few lesions and increase in the size of the other lesions. That means that there is a heterogeneity in the tumor population, and obviously the loss of expected TKI sensitivity. Now, I'll just quickly go through what is the treatment strategy that we have as of now on de novo SCLC. That's a recap. So obviously, if it's a limited stage, now we would be looking at, if it's N0 disease T1, T2, we would be looking at a surgical resection even today. And followed by that, we would be looking at etoposide cisplatin 4 cycles. Now, in case if it is node positive, post resection or R1, R2 resection, then we would be looking at concurrent CTRT. If it's a stage 1 to 3, that is obviously a T1 to T4 disease, but with node positive upfront, then we would be looking at giving a concurrent CTRT or a sequential CTRT. I'm not going to into the details of concurrent versus sequential. I think that is a big debate which goes on all the time. So, and then, for example, after that, if we have no progression, then again another debate comes into the picture of whether to give a PCI versus a MRI brain surveillance every 3 months. That is another debate for another day, actually. Coming to the extensive stage, we have excellent data of the IMpower 133 with atezolizumab and the Caspian study with durvalumab. And so when we look at the extensive stage treatment, we see that we have, if it's a PS021, we have etoposide carboplatin with atezolizumab, or we have durvalumab into the picture here. And then there are also, if there is a contraindication of IO in this scenario, then we will be giving chemo for 4 cycles, followed by a consolidation RT can be also considered. If it's a recurrent SCLC, which is in the second line, we are spoiled for, we did not have much of choices previously, but then newer molecules have come into the picture. And if it is a platinum resistant relapse that is less than 3 months of TFI, then we can consider lurbinectedin, or we can also consider topotecan based regimens. But then generally in our practice, I think irinotecan is an easier drug to handle, and we have more experience with irinotecan. So I did see a few patients who were undergoing got irinotecan in my practice. Coming to the platinum sensitive relapse, the rechallenge with platinum with etoposide seems to be a viable option. Now, I think few days back, Onco Brothers is a very famous channel that we have in Twitter and YouTube, and I was just going through their video, and obviously there is some exciting data that has come. Let us go to the extensive stage, and if we see that extensive stage platinum-based chemo plus atezolizumab is followed by a atezolizumab with lurbinectedin maintenance. Now, the whole idea of lurbinectedin with atezolizumab is basically because of a synergy where lurbinectedin is known to increase the infiltration of the immune cells. But then the data did not show a lot of benefit. There was PFS, there was OS, but there was no tailing of the curve, which effectively says that lurbinectedin may not be the best synergistic molecule with atezolizumab. But as of now, there is exciting data coming. And then obviously we have tarlatamab, Dr. Rui was mentioning, and I would also come back to that with the DLL3 expression later. So now the thing is that we were talking about de novo. Now, what happens if there is transformed SCLC, and we have multiple people looking into such? But then the trouble is that there are so much of less data in the database that we are only having like 100 patients or 200 patients in the last 10 years. And then there have been multiple authors, Sequist, TU, Nidist, and then Marcoy, Salfield, and Catania. I think I'm going to just talk about 2 of such papers. If you look at the Salfield data, then they took 47 patients, and the setting was a post-TKI setting. And they found out that there was they had 3 arms, and they tried to compare chemo plus IO, or chemo plus TKI. And they found out that there was similar PFS and OS across all the 3 arms. Similarly, Catania, that was also a very significant recent trial that was done on 25 patients post TKI. Again, there was no OS advantage for adding any of the immunotherapies or TKIs. So if we see the range between all these trials, we see that the PFS is hardly 2 to 5 months, and the OS is also something which is, even though it's 9 months, but then it is not very consistent throughout the population. Now, there is some available data which suggests that DLL3 expression, which was shown by Saalfeld, is upregulated upon transformation in EGFR mutant NSCLC. So there is some retrospective analysis that has been done in these population cohorts, and they have found out that those patients did have some DLL3 expression, which means that if there is a transform SCLC, the role of tarlatamab may become more consolidative in this picture. Catania, as I told, had seen 25 patients, out of which 24 patients were extensive stage, and EGFR were retained in all the 14 patients where the samples were shared. And then we see here also that it is a abysmal PFS benefit of 2 months and OS benefit of 9 months, which is good, but then we don't have much difference between the OS of CT along versus ICI or TKI. Now, when I was preparing for this slide, and obviously we are not aware of such scenarios, but there was a paper in ISLC journal which showed a case report of the first patient who was an ALK-D agonist in SCLC, and he has transformed into SCLC. And this patient has really responded to tarlatamab. So if we talk about tarlatamab, then it is a DLL3 A notch pathway inhibitory ligand, which is highly, basically what is DLL3 is an inhibitory ligand which is highly expressed on the SCLC cell surface and which can be used as a target. So in this patient, there was initially they had given crizotinib, then alectinib, and then they found out there was progression, and then post progression they did a biopsy and they found out that it's SCLC. When we see when we dig into there is a JCO Precision Oncology paper, which was a multi-institution analysis of tarlatamab for the treatment of EGFR mutant transformed small cell carcinoma, and we see here that even though there is a 40% ORR that is seen in de novo SCLC with a PFS of 4.9 months, but when we go to a transformed SCLC cohort, we see that the clinical response is only 7%. Now, even though these are all retrospective data and have been collected from multiple institutes because of the lack of real cases that we have in the real world, the explanation of this discrepancy may be clinical or biological, where clinically these patients may have been treated heavily for NSCLC previously. Maybe the performance status was generally lower than the patients enrolled in the trial, and obviously that there can be a difference in the responsiveness to therapy because this is not a trial, this was just a retrospective analysis. Now, obviously, we know that we are clear about that the backbone of platinum plus etoposide has to be given in a transformed NSCLC. There is no doubt in that. But then what data do we have, and what subset analysis do we have to see that in these trials of Caspian, IM-powered 33, how many of them were transformed SCLC? The authors did go back and retrospectively look at it, but they did not find any convincing OS benefit. Smoking history as a de novo SCLC is strongly tobacco associated, but transformed ones are often never smokers because they are the EGFR mutant population. The TMB, because of the smoking new antigens, high TMB is seen in the de novo population, but here it is transformed SCLC, it is lower TMB and it has a different immune microenvironment, which may explain why immunotherapy is not working as well. And the ICI outcomes, if we see that there has been very limited outcomes. Marco did a paper where they found out that 17 out of 17 patients, none of them responded to immunotherapy. So the practical management approach would be that we have to obviously individualize treatment. TKI continuation, it is actually a non-standard. So if someone is transformed into a SCLC, I would say that we should stop TKI. So there is no benefit, rather you are just adding to the financial toxicity. Thoracic RT, yes, for limited stage or symptomatic bulky disease, we can do that. CNS management, brain MRI surveillance versus PCI or CRS can be done if there is a symptomatic brain met. And then obviously later line therapy, there are data showing that taxanes may be used and got some 50% response rate as a second line after PEMSIS or PEMCARBO. And repeat biopsy, there is no doubt that we have to do it at a later progression. And ideally, we should do it from the new lesion which has come up so that we can understand the heterogeneity. So obviously it's an unmet area and we don't have much data. Most of them are all retrospective. I don't know how much prospective trials would be possible in such a rare scenario. Translational tissues are very important. Biomarkers, we should check the RB1 and the D53 and diagnosis, and then maybe predict from that. DLL3 oriented research is coming up. And then obviously that transformed SCLC is not molecularly identical to primary SLC. So there has to be a distinct drug development. And there is some emerging tool coming up, which was shown by Lee et al. In 2024, is epigenomic cell-free DNA profiling, which may enable that, which is a non-invasive detection of small cell transformation, and which may give us a nice idea of how the transformation is happening. So the conclusion for a clinic, for 4 take-home messages: transformed SCLCs are very important lineage plasticity, but then they often retain the EGFR mutation, but they behave like a EGFR independent neuroendocrine disease. So mutation is retained, but dependency is lost. For as of now, tomorrow you should consider platinum etoposide obviously as the backbone, but then whether to add immunotherapy to that would be a discussion that you should have with the patient, and tell them that you may not derive as much benefit as other patients, and the outcome remains still poor. Even though we have had excellent data on SCLC, as Ruhi mentioned, there is serplulimab data, but then how much of that data will transform into of this kind of SCLC, we don't know yet. With this, I would like to end my talk. Thank you so much to the organizers again for giving me the platform to head the session as well as give my talk today. Thank you so much.
Thank you, sir. Thank you for insightful presentation. So we will now open the floor for a short question session. Participants are requested to post their question in the chat box.
I think there are no questions, so we can close the session and over to the organizers.
Okay, sir. So as we come to the end of the enriching session, I would like to sincerely thank all our distinct faculties for sharing their valuable insights. I also extend my gratitude to all participants for joining us today. All the participants will be receiving certificate 4 to 5 working days to a registered mail ID. On behalf of IAIO, thank you once again. Have a great evening ahead. Thank you, everyone.
Thank you so much. Good night.
Thank you. Thank you. Good night.
Thank you, Deepatya. Thank you.